Good afternoon. Myself, Dr. Amrita Kumari, Senior Lecturer from Department of Periodontology. Today I will be discussing on the topic supportive periodontal therapy. So now coming to the introduction, preservation of periodontal health of treated patient require a positive program as that required for elimination of periodontal disease. After phase 1 therapy, patients are placed on a schedule of periodic recall visit for maintenance care to prevent recurrence of disease. So transfer of patient from active treatment status to maintenance program is a definitive step in total patient care. So these are the process. First we go for phase 1, that is non-surgical therapy. After non-surgical therapy we go for re-evaluation, and then we go for the maintenance phase, that is phase 4. And again if phase 2 is required, that is periodontal surgery, if it is required, then we do it. And then after phase 2 again we go for phase 4, that is maintenance phase. And then after that if phase 3 is required, then we do it, and after that again we'll go for the maintenance phase, that is phase 4. So now coming to the maintenance program, periodontal care at each recall visit comprises 3 parts, that is first examination, approximately time 40 minutes, that include medical history changes, oral pathologic examination, oral hygiene status, gingival changes, pocket depth changes, mobility changes, occlusal changes, dental caries, restorative, prosthetic and implant status. And coming to part 2 treatment, approximate time 36 minutes, oral hygiene, reinforcement, scaling, polishing, chemical irrigation or site specific antimicrobial placement. Part 2, then there is part 3, report, cleanup and scheduling, that is for 10 minutes. In this it includes write report in chart, then we discuss report with patient, then we clean and disinfect operatory, then schedule for next recall visit, then we schedule for further periodontal ligament treatment, then we schedule for or refer for restorative or prosthetic treatment. Then first coming to examination, similar to initial examination, patient is not new to office, dentist primarily looks for changes that has occurred since last evaluation. Then we go for radiographic examination, must be individualized depending on the initial severity of case and finding at recall visit. These are compared with finding on previous radiograph to check bone height and look for repair of osseous defect, sign of TFO, that is trauma from occlusion, then periapical pathologic changes if there, and the caries. Then in radiographic examination, periodontal ligament disease not under good control. If there is not under good control, then we take the periapical or vertical bite-wing radiograph of problem areas every 12 to 24 months, full mouth series every 3 to 5 years. Then history of periodontal treatment with disease under good control, that is bite-wing radiograph at 24 to 36 months, full mouth every 5 years. Then root from dental implant we 6, 12, 36 months after prosthetic placement, then every 36 months unless clinical problem arise. Then classification of post-treatment patient. First year, that include 3 parts. The first year after periodontal therapy is important in recall pattern and reinforcing oral hygiene technique. Then second, patient who are on a periodontal recall schedule are a varied group. Then marine classification, recall intervals for various classes of recall patients. So this is the marine classification. In marine classification there is first year. In this characteristic are routine therapy and uneventful healing. In this include difficult case with complicated processes if there, furcation involvement, poor crown to root ratio is there, or questionable patient, then we recall interval should be 3 months and 1 to 2 months for these difficult cases with complicated processes. Okay, then in class A, in this, if there is excellent result, well maintained for 1 year or more, and if there is good oral hygiene, there are no occlusal problem, no complicated processes, if there is no remaining pockets, there is no teeth with less than 0% of alveolar bone remaining, then the recall interval is then 6 months to 1 year. And then coming to class B, if there is generally good result maintained reasonably well for 1 year or more, but patient displays some of following factors like inconsistent or poor oral hygiene, heavy calculus formation, systemic disease that predispose to periodontal ligament breakdown, some remaining pockets, complicated prosthesis, ongoing orthodontic therapy, then recurrent dental caries, some teeth with less than 50% of alveolar bone support, positive family history, more than 20% of pocket, then bleeding on probing, then we recall the recall interval, then it is 3 to 4 months, and we decide on recall interval based on number and severity of negative factor. Then coming to class C, in this, if there is generally poor result after periodontal therapy and or the several negative factors from following list, like if there is inconsistent or poor oral hygiene, if there is heavy calculus formation, if systemic disease that predispose to periodontal ligament breakdown, many remaining pockets, if there is occlusal problems, if there is complicated prosthesis, if there is recurrent dental caries, periodontal surgery indicated but not performed for medical or financial reason, if there is many teeth with less than 50% of alveolar bone support, if the condition too far advanced to be improved by periodontal ligament surgery, if the patient is smoking, if there is any positive family history, and if there is more than 20% of pockets or bleeding and probing, then the recall interval is through 1 to 3 months. Decide on recall interval based on number and severity of negative factor. Consider retreating some areas or extracting severely involved teeth. So referral of patient to periodontist, class A, B, C, like class A mild or localized, B moderate or advanced. So maintenance for dental implant. Now patients with implant are susceptible to a form of bone loss called periimplantitis, and patients are more prone to plaque induced inflammation with bone than those with natural teeth. So in general, procedure for maintenance are same, but following 3 differences are present, like special instrumentation are there that will not scratch the implant, are used for calculus removal on the implant, like metal hand instruments and ultrasonics and sonic tips avoided as they can alter titanium surface. Plastic instruments or especially designed gold plated curettes used for calculus removal. And second, acidic fluoride prophylactic agents are avoided. Third, non-abrasive profile paste are used. Thank you.